Bismillahirrahmanirrahim. Assalamu alaikum. Today our topic of discussion is about foreign bodies inside the eye. These foreign bodies may be metallic, may be non-metallic, may be plastic, may be glass. So today we are going to discuss about their different causes, their clinical manifestations, their complications, and how this problem can be treated. When we talk about the foreign bodies entering into the eyes, usually these happen because of any trauma or any injury. This may be occurring with people who are working with construction industry, doing welding job, using hammer and chisel job over there, or anything where they are using some instrumentation and not taking protective care, not using those protective goggles, which we have discussed earlier in our video of eye protection in detail. These problems happen. So what happens that when a small piece, for example, of metal, wood, plastic, glass, it breaks apart from the main part, it enters into the eye and enters with such a speed that first of all it damages cornea, as shown in this photograph. Then it passes through the lens, as shown in this photograph, which has become now cataract, opaque. Usually it is transparent, and anything which comes in its way, it keeps on penetrating and it goes into the inside of the eyeball. It may enter through the sclera, the whitish area, and any route it can acquire, and it goes on until it can sometimes go to the retina, and it can pass through it, even that through the retina also. So this is a photograph. Let's concentrate that there was an injury and which was repaired by surgeon with interrupted sutures. Of course, this is the anterior portion, emergency repair, and now this patient has got cataract, shown in blue arrow, with there is some blood. You can also see this is just behind the cornea in anterior chamber. And now what's happening in such patients, usually what happens in the back, we will see in a patient who does not have the cataract, and now we will see the fundus photograph. Here we have taken the fundus photographs with the retinal camera, and as I mentioned that the view was clear. So here you can see a small foreign body, the metallic foreign body, which is residing inferiorly, most likely at 6 o'clock position shown by arrow. The retina is flat in the fundus photograph. And apart from this, in the other we use special filters. There's an autofluorescence, and again in autofluorescence it is showing again at 6 o'clock position the presence of the foreign body, metallic one, occupying the inferior part. The ultrasound of the eye, which we call B-scan. Here you can see that sometimes when there is blood all over there, and as I showed in the first photograph, the cataract, we cannot see anything, then we take the help of this ultrasound, and in this ultrasound the sonographer has shown that in the red circle over there, there is a foreign body, metallic foreign body over there, which is present, and it has passed through all different layers, as I mentioned, sometimes to the cornea, and sometimes it takes a direct route to the whitish area that we see over that sclera. So it is over there in ultrasound. So ultrasounds are very helpful when we cannot see, and when we cannot find it over there. But the important thing is that if there is a globe rupture, if there is a trauma over there in the eye, eyeball is cut, because of any reason, ultrasound should not be done. It is contraindicated. This procedure can be done once the globe has been repaired properly, primary repair has been done, all the wounds have been secured, and later on, very gently, the sonographer tries to find out the location of the foreign body. In open globe, when eye is cut, iris is coming out, and all these things happening, this procedure is contraindicated. These are some other photographs shown. In the ultrasound, again, another patient. Here you can see there is a vitreous hemorrhage shown in the blue circle over there, and along with that there is high suspicion of retinal detachment over there. So when there is globe rupture, such patients come to us. The other thing is we take the help of imaging, that is CT scan. Especially in the CT scan view, here you can see the red one, the red circle, exactly and precisely tells us the location of a foreign body lying over there posteriorly. And the blue arrows are basically tells us about the optic nerve, its situation, which takes the current, which takes the signals from the eyeball. So CT scan is also very helpful in such patients who earlier present to us and we want to rule out any metallic piece, any wooden piece, plastic, glass, vegetation, anything in the eye. It is very helpful and it clearly tells us. Whenever there is a metallic foreign body in the eye, MRI is contraindicated. That cannot be done. So CT scan is very helpful in this aspect. There are some other views again in the red arrow and the blue circle, again showing us the presence of the foreign body inside the eye. Now once the foreign body is there, it is something very urgent. It has to be removed because it has other complications which we are going to discuss. When we talk about the foreign bodies inside the eye, the thing which will determine the prognosis, the results, is what is the type of the foreign body. Is it metallic, vegetable, wood, plastic, or inert? Size, small or large size, and its location, the damage, how far it has gone over there in the eye. If we talk about the metal, for example, iron and copper, apart from causing the mechanical damage, these metallic foreign bodies, the small pieces of metals, they can undergo chemical reaction over there, chemical changes, and these changes, which we call siderosis in this term of metals, they can damage the eye. Not only mechanical but chemical things are also happening over there. If we talk about the woods, wooden material, vegetation material, they are very prone for the fungal infections. Yes. And any dirt over there, plastic or like this, no doubt the speed is very much of these things for entering the eye. But any microorganism over there which they carry, they can cause a lot of infection inside the eye. So this is something very urgent. So it is the type of the foreign body which is entering into the eye, its size and its location. If it goes up to the retina and it causes retinal detachment and retina has moved from its place, then the prognosis and the results become less. I mentioned that when a patient comes, we have to take the preliminary examination. We have to check his vision, first of all, of any eye examination, visual acuity. Then we have to do examination damage, which layer, which area is involved. We can use fluorescein eye drops to see any leakage from the anterior chamber of the eye. Proper documentation over there. All these, as I mentioned, images. X-rays can be very helpful in radio opaque materials, these metals, but in case of plastics, in glass, they are of limited benefit. So after this preliminary examination, the eye is covered with a plastic shield, IV antibiotics are started, painkillers are given, and if patient is not protected by tetanus toxoid, he should be given, and the patient should be prepared as an emergency for the repair of the main wound over there. So it depends that the foreign body which has entered in the eye, as shown in the first photograph, is it anterior to the lens or it has gone beyond the lens? If it is anterior to the lens, the management is different. The first thing is the repair, localization of the entry wound, and it should be stitched, it should be sealed, it should be repaired. Once the wound has been repaired, then the surgeon can remove the foreign body in the anterior chamber on the lens surface by making another entry wound, another port. The foreign body should never be removed from the damaged area, from the cut area of the eye. That must be repaired first, and a new port, new entry should be made and the anterior chamber should be formed with viscoelastics, and that should be removed. If it is metallic, we can take the help of magnets, and with gentle manipulation, minimal damage to the corneal endothelium, we have to protect cornea back, and it should be taken out. If the patient has cataract surgeries, many surgeons opt to go for the straight way in that setting to remove the soft cataract and put the lens, but better to let the inflammation settle down, let the activity which is going on and get under control, and in the second setting that cataract can be removed and a proper lens of proper calculation can be put to the eye. This is when we are talking about the foreign body, the metal or wood or plastic or anything, or even cement in the labor industry, in construction industry, that enters but remains anterior to the lens. So this way it can be removed. But in the case the foreign body goes beyond the lens surface and it has gone into the vitreous cavity, or it is residing over there in the retina, then the vitreoretinal surgeon, the posterior segment surgeon, has to come and do the job. He has to do pars plana vitrectomy, and with that, if there is retinal detachment, he has to manage that one also. If there is any retinal break, no retinal detachment, he has to secure that break to prevent retinal detachment. If there is any vitreous hemorrhage, that has to be removed. But the most important thing I mentioned, whether it is anterior or posterior foreign body in the eye, the timing is very important, and the quick decision making and the management. The reason is the delay we do, the patient is more prone to infections, and once the infection develops into the eye, that we call endophthalmitis, then the prognosis becomes very low, very bad prognosis. So timing is very important. But above all these things, as I always mention, and I have even discussed this in my previous videos, prevention is always better than cure. The patients should be encouraged to use protective goggles and protect their eyes before doing any type of such jobs. So today's this was our topic of discussion, that how with fast speed and velocity these foreign bodies, even very small in size, can penetrate through the eye, through different structures, and ultimately they can damage anything, and you have to do multiple procedures to restore. And in spite of all the surgeries, that pre-damage vision cannot be guaranteed. But the timing, as I mentioned, is important to prevent further damage and infection and endophthalmitis. I hope my today's presentation will be beneficial to my respected audience, especially about examination and imaging and different approaches for the removal of the intraocular foreign bodies. I want to thank you for your attendance and attention. Thank you.